Thank you so much, Johan, for this very kind introduction. It's my great pleasure to be here. I don't have, as a president, any influence on the program. I didn't ask for this talk. Anyway, I'm super happy to be a part of the panel. In the next minutes or so, I will try to draw a picture of what we know about a rare orphan disease variant which belongs to the psoriasis spectrum. And you'll see that I will also discuss the intersection with the most frequent variant of the psoriasis spectrum, which is plaque psoriasis. These are my disclosures. So assumingly the genetic architecture of generalized pustular psoriasis, or as GPP, relies predominantly on a single gene model. So this is based on first multiplex families that we knew for long, that they exist mainly but not exclusively. It could be following some Mendelian segregation according to autosomal dominant or autosomal recessive model. Early onset disease, sometimes it's a neonatal period, and also this big blowout of cytokine release leading to this very severe disease, at least in the severe forms, that would make scientists suspicious that would be a major genetic abnormality driving the process. And you'll see that there are different genetic architecture backgrounds. Of course, this is, again, assumingly very different from the multigenic genetic architecture model, which is supposed to underlie the psoriasis vulgaris. So 12 years back, two groups and then followed by others unraveled the presence of the mutation in a gene encoding for the IL-36 receptor antagonist belonging to the IL-1 family. The gene is called IL-36RN, and when there are some loss of function mutation, essentially in homozygous or composite heterozygous setting, it leads to these GPP attacks. But you see on this slide, I think the pointer is not, it's not working. You see that on these slides that these are chronic lesions in between the flares. All these patients, they carry the same mutation, which is a very severe mutation called the L27P, leading to the absence of any antagonist. And so many of these people, they have geographic tongue. Some, they have acrodermatitis continuo-alpha-lopo-like lesions in between the GPP flare, flexural pustular psoriasis, and sometimes plaques with a little bit of pustules on the periphery. So the first take-home message, yes, there is a common denominator, GPP, following the von Zumbusch description, but also some clinical heterogeneity, although they carry exactly the same mutation, and this was thanks to the collaboration with our colleagues, Slahedin Marakchi in Hamida, Turkey, and Tunisia. So there are no hypomorphic IL-36RN mutations in generalized pustular psoriasis. Then they were identified in acute generalized exanthematous pustular eruption following some considered as a drug eruption. And it seems that there are some hypomorphic mutation accounting more for the localized form ACH or sometimes palmoplantar pustulosis, although they are very seldom found in the context of PPP. So the second message was that in one pedigree, there could be very much heterogeneous clinical severity. This is a pedigree which is where the disease, the GPP, is in the index case is resulting from the substitution of the amino acid substitution at the very cleavage site that transformed the immature form of the antagonist into a mature form of the antagonist. So in the absence of this cleavage, you don't have bioactive alpha-6 receptor antagonist. And you can see that one of the siblings has only a geographic tongue, the other ones have true GPP, and they are very different severity representation. So of course, the deficiency in alpha-6 receptor antagonist, if you want to define this disease according to this disease taxonomy, there's not only GPP, right? And this is something that this is debatable to follow the molecular or the clinical description or both. And second, the transcriptomic studies started in the skin and the blood. This is just showing the blood in the context of SARS-CoV-2 induced GPP flare in the patient with the V2F mutation I was just presenting in the previous slide. And even in this context, what has been found in some patients by other group, Francesca Capons and also Johan Gudjonsson, meaning a type 1 interferon signature, at least in the blood, was not seen, although it was very soon after a viral trigger. And you can see there is a strong neutrophilic signature, which is expected to be the major signature, and this is again in the blood by nanostring analysis, and the interferon score is in the normal range. Other genes have been identified, or genetic abnormalities accounting for GPP. So CARD14, I will allude to that, is an innate immune gene. All these genes, they belong to the innate immune system. AP1S3, identified by the group of Francesca Capon, involved in innate immunity and keratinocyte autophagy, which is increasing the alpha-6 alpha encoding gene at the transcript level, accounting for GPP, acropustular eruption, but also palmoplantar pustulosis in some cases. Serpine3, which is connected to the alpha-6 as well, and the myeloperoxidase by the group of Musner and Francesca Capon, again in the London, UK, accounting for GPP mainly, ACH, and acute generalized pustular eruption. So what is interesting is to pay attention to the CARD14 one, because the CARD14 mutants are mainly heterozygous, sometimes homozygous or composite heterozygous. But the main model is heterozygous gain-of-function mutation. This is a keratinocyte expressing gene. So the mutations were identified, interestingly enough, first by Anne Bocock in the Mendelian form of psoriasis vulgaris plus or minus psoriatic arthritis, pityriasis rubra pilaris, and pustular psoriasis, essentially GPP, but also palmoplantar pustulosis. And I attract your attention to the, here, this is a mutation in red, which is intersecting, meaning the same mutation has been identified in cases of Mendelian psoriasis vulgaris, in PRP, pityriasis rubra pilaris, but also in GPP. So there should be at least some CARD14 mutants are accounting for, different phenotypes that we think that are completely separated. So there should be something that is, at least in some cases, unifying concept in the so-called CARD14 disease. And most of the CARD14 mutants are located in the CARD and COD domain, accounting for more than 60% of the published variants. And what is interesting is that the knock-in in mouse sort of reproducing one of the heterozygous mutants leads to a psoriasis-like disease where you can see the presence of neutrophils as macroabscesses in the epidermis, and increasing the response of keratinocyte to IL-17A, and to at the same time with a neutrophilic signature. So this probably and surely accounts for the for the fact that most of the patients with CARD14 a gain-of-function mutation, at least for psoriasis vulgaris and papulosquamous eruption related to the CARD14 mutants. They respond very well to IL-23 and IL-17 blockers. We don't know if this is the case in the context of GPP, and I think that's something that we should really explore to tackle the IL-17 inhibitors response in the context of the mutations, and it will explain at the end why. So pathogenic mutations in GPP, the prevalence of the IL-36RN mutations varies across studies, but more or less, I mean, this is a study, again, on a large panel of patients using different methods. The coverage was not completely exhaustive, but this deserves some credit because it's a large set of patients. You can see that 23.7% were IL-36RN positive. Just one comment, in families where it's an autosomal recessive model, in the Tunisian family, there was no case of GPP in heterozygous carriers, meaning that it's questionable, it's debatable if the heterozygous, they have really a phenotype. But anyway, for the homozygosity, you can see that this is Francesca Capone's work in a large panel of patients. Here, in a total of 46 patients with GPP, you can see that the proportion of patients with homozygous mutant, it's roughly 22%, so very close to what was found by the Capone's group, although we have a lot of patients from North African descent in France. And you can see that the other players are underrepresented. AP1S3, 6.6%, and CARD14 is 4.4%. Myeloperoxidase, 2.2%. SERPINA1 is, the causality is not very well established, unlike SERPINA3. What is also interesting is to pay attention to the molecular profiling studies in GPP and the comparison with psoriasis vulgaris. And I emphasize this very nice paper from Andrew Johnson and led by Johan Gudjonsson. And you can see that in the lesional skin of patients with GPP versus PV versus healthy skin from healthy individuals, you can see that, yes, the IL-36 sort of transcriptomic signature is stronger at the population level, but there are some patients who are really at the same level. And what is also interesting, well, the IL-23, unsurprisingly, is higher for the mRNA expression in the psoriasis vulgaris, although there is a large variance inter-individuals. And what's interesting, MX1 as one of the interferon-stimulated genes, you can see that the two populations, they emerge some individuals with a type 1 interferon signature, which is quite strong. So there might be an intersection between the two diseases, at least for the type 1 interferon signature. That's something that we are very interested in exploring. And also the top 20 upregulated genes, so you may say, these are very different diseases, psoriasis vulgaris and GPP, because we don't find the IL-36RN mutations in psoriasis vulgaris. That's crystal clear. And the patients with both psoriasis vulgaris and GPP, you have an underrepresentation of the IL-36RN variants. So the IL-36RN is not the driver of the association between psoriasis vulgaris and GPP. But the top 20 upregulated genes in GPP and in PV, they are identical. And that's quite puzzling. But the magnitudes of the upregulation, the difference, of course, they are much higher in GPP, IL-1B, IL-36A, IL-19, CXCL8, and CXCL1, CCL20, SERPINB3, and SERPINB4, and so forth. So yes, these are different diseases, and I don't have to have a recap of the pathogenic scenario in psoriasis vulgaris. This was brilliantly exposed by Johan Gudjonsson. But this sort of hermetic separation between the two diseases is sort of contradicted by the epidemiological facts that you have roughly 40 to 50% of the patients with GPP, they have concomitant psoriasis vulgaris. So that's clear. And IL-36 RN mutations are not driving this association. So there should be another player. What is also clear that a question is, should we reconsider disease taxonomy? Speaking of CARD14 associated disease, instead of, the classical description, classification and taxonomy, or probably re-importing the clinical description and sort of classification into the molecular context. That's probably something we should do. But it matters regarding the treatment because the deficiency of IL-1 receptor antagonists, which leads to these pustular lesions, GPP-like, but with bone deformation that you don't find in the deficiency in IL-1, IL-36 receptor antagonists, the DTRA. Of course, you won't treat the same these two diseases. So it does matter in the monogenic model to have a molecular classifier. And again, more than 40% of the patients with pustular psoriasis, they have also concomitant plaque psoriasis. So what is the connection? We don't know. We suspect there is another genetic determinant. It's not CARD14 because it's quite marginal at the population level. It's not IL-36RN. There should be some other genotypic determinant responsible for that. Now, the consequences on the treatment were that from the description of the genetic architecture of GPP, there were the drug development of IL-36 receptor inhibitors. So I will be quite quick, but the first of that kind is spesolimab, a humanized anti-IL-36 receptor monoclonal antibody developed by Boehringer Ingelheim. This is the design of the phase 2 study that was published 2 years ago, where a single IV dose of spesolimab was basically compared to placebo according to a 2-to-1 ratio, and the primary endpoint was GPP-GA pustulation score 0 at week 1, and the study was going through week 12. So to make a long story short, I mean, there were quite balanced demographics from between the two groups, and you can see that according to the primary endpoint and the secondary endpoint, 54% of the patients receiving spesolimab that reached the primary endpoint versus 1% of the versus 6% of the patients receiving placebo. Only one reached the primary endpoint, and that was roughly the same for the key secondary endpoints, the GPP-GA total score of 0 or 1 at week 1. And what was observed at week 1 was confirmed at week 12. This is a GPP-GA postulation subscore of 0, and you can see that the patients initially receiving placebo and were switched to the spesolimab group, they capture a strikingly effective response regarding the eradication of postulation subscore, and the same applies for the GPP-GA global score. There is this is the imsidolimab randomized. This is imsidolimab phase 2 Gallop trial. Sorry for the mistitle. Developed by Anaptys Bio, and you can see the following: an IV dose and the sub-Q injection. The CGI, according to the GDA, which was the primary efficacy endpoint, a lot of patients of week 2, this is only 7 patients, were either much improved, very much improved, and that was true as soon as week 1. So again, a very quick effect. And this is the phase 2b flare prevention study of spesolimab, which was communicated at the AAD this year. And again, different regimen were compared to placebo in patients who are included when they have a 0 to 1 GPP-GA score, and to make a long story short, these are the demographics. Here, there was a clear superiority of the spesolimab high dose, with only 10% roughly of the patients showing only one flare up to week 48, versus 51.6% of the patients receiving placebo. So this is a demonstration that not only it treats acute flares, but also it's preventing the flares. The safety was good, some arthralgia. So in summary, the identification of genetic architecture, pustular psoriasis and psoriasis-like disease unravels the key contribution of inborn errors of the skin's immune system, innate immune system. These single gene models allowed the design and further approval of targeted therapies, spesolimab in moderate to severe acute flares of GPP, and the phase 3 imsidolimab studies, the top line results have been the subject of a press release. However, the one targeted therapy fits all paradigm doesn't fit with the genetic heterogeneity of the disease and its mechanistic consequences, and pave the way for a precision medicine approach. And I would like to thank you for your attention.
Thank you very much.